areas where a neuroanesthesiologist has to have an increased role. Pediatric neuroanesthesia is one of the areas which requires again a specialized skill set so as to ensure a safe perioperative and post-operative outcome in this subset of population. And many a times this poses tremendous stress and challenge upon the attending anesthesiologist. This is one simple example. We had at All India Institute of Medical Sciences a craniophagus, which was operated, and there was a dedicated team of neuroanesthesiologists that worked day and night for around 2 months till these babies were discharged from the hospital. Then we have a complex set of surgeries around the upper cervical spine, where we have difficult, challenging airways which need a special management of these patients. Then in the intensive care unit, we get severe brain injury or spinal cord trauma, which poses tremendous challenge. And the neuroanesthesiologist has to have a thorough knowledge of the various neuromonitoring techniques, whether it's ICP monitoring, its knowledge of the invasive and the non-invasive techniques that are recently being introduced in all intensive care units, the knowledge of the transcranial Doppler, and in the recent years, as I was just pointing out, the functional neurosurgery, it is playing an important role. We have a surgery being performed for the tremor. We see the patient before surgery, he has a tremor, the implant is being introduced by the surgeon, and after introducing the implant, we see the tremor has disappeared. And neuroanesthesiologist is always accompanied by armamentarium of electrophysiology, and he informs rightly the neurosurgeon about the probable improvement in the pathological and the clinical status of the patient. A point of care, a primary physician, the neuroanesthesiologist and a neurointensivist, they may attain a primary care physician in the future. We have various diseases, particularly patients with subarachnoid hemorrhage, intracerebral hemorrhage, where the care starts from the point of time when the patient is admitted in the hospital, in the intraoperative period, and post-operatively in the ICU. A neurosurgeon, a neuroradiologist, he comes and goes, but with the introduction of the subspecialties, a primary care physician may be the primary role. This role may be assumed by a neurointensivist in the future. So many patients who are suffering from traumatic brain injury, spinal cord injury, spinal tumors, they may be definitely helped by the improvement and the development in this subspecialty. Then a lot of patients with various pain procedures, they do present to various neurocenters where we have dedicated teams of neuroanesthesiologists, and a lot of work has been done in the recent past by various neurointensivists. So we have a role for some neuroaxial, we have a role for some blocks, particularly in neurocenters, the trigeminal block, the Gasserian ganglion block, and then we have the stellate ganglion block, which is also used for the treatment of cerebral vasospasm. And brain being an ill-understood organ and the complex nature of pathologies that we have, there is a huge opportunity for youngsters to delve into these areas, and there's a huge area for research for our youngsters who can take research into neurocritical care and neuroanesthesia as a career. So what are the training opportunities? Right now in India, we have a DM neuroanesthesia and critical care, which is a 3 years course. It was initially There were 2 centers, All India Institute of Medical Sciences, New Delhi, and Sri Chitra Tirunal Institute of Medical Sciences, Trivandrum, where it was introduced. But right now, we have around 10 centers, including National Institute of Mental Health and Neurosciences, Postgraduate Institute of Medical Sciences, Chandigarh, JIPMER, Pondicherry, and we have AIIMS Rishikesh, AIIMS Bhopal, AIIMS Bhubaneswar, CMC Vellore, and JIPMER. Out of these, we have an INI super specialty test that is conducted from the anesthesia mainstream, and at the same time, we have a NEET super specialty test for CMC Vellore and JIPMER, New Delhi. At the same time, we have various institutional courses. These are 1-year institutional courses which are offered by Sri Chitra Tirunal Institute of Medical Sciences, Trivandrum. We have SGPGI Lucknow, Banaras Hindu University, Varanasi, Aligarh Muslim University, NEMS Hyderabad, Government Medical College, Nagpur. These are some of the institutes which offer a 1-year course. And at the same time, we have postdoctoral fellowship in neuroanesthesiology offered by NIMHANS, Bangalore. Again, we have institutional, national level entrance examinations for admission to these courses. Then we have the National Board of Examination, NEET super specialty examination. Currently, there are 9 centers in India which are offering DRNB neuroanesthesia. We have Sher Kashmir Institute of Medical Sciences at Srinagar. We have Apollo Hospital, Hyderabad. We have Sahyadri Super Specialty Hospital, Pune. And we have Apollo Hospital, New Delhi. We have Institute of Neurosciences, Kolkata. And we have Kokila Bean Ambani Hospital, Mumbai. Medanta at Haryana, Hinduja Hospital in Mumbai. And we have Paras Hospital, Gurugram. So admission to these courses is again through the NEET super specialty examinations conducted at the national level. Now, we also have ISNAC neuroanesthesia fellowship courses. These are 1-year courses, and we have around 20 institutes which offer this 1-year fellowship course across India. So we have Fortis Memorial Research Institute at Gurugram. We have Max Hospital, Saket. We have Institute of Neurosciences, Kolkata. And we have AIG Hospital, Hyderabad, Fortis Hospital, and Max Super Specialty Hospital, Dehradun. This we have again Sakra Hospital in Bengaluru and Ramaya Institute of Neurosciences at Bengaluru. We have Artemis Yashoda Hospital, Kasturba Medical College, Jaslok Hospital, Sir Gangaram Hospital, and National Neurosciences Center at Kolkata. And we have Gitanjali Medical College at Udham. In the last 4 to 5 years, we have neurocritical care courses that are conducted. We have 2 institutes of national importance. That's the All India Institute of Medical Sciences, New Delhi, and the National Institute of Mental Health and Neurosciences, Bengaluru. So they are conducting the postdoctoral fellowship in neurocritical care, and the eligibility for this is DM in neuroanesthesia or MCH in neurosurgery and DM in neurology. At the same time, we have the ISNAC neurocritical care courses. They are conducted at multiple centers across the country in Bengaluru, Kolkata, Dehradun, and New Delhi. And we have one overseas fellowship, neurocritical care, which is being carried out under the shadow of ISNAC at Brunei. Again, we have fellowship in neurocritical care. This is carried at multiple centers, again, across the country in Gurgaon, Vellore, Pune. We have in Coimbatore, 2 hospitals are running. And then we have one dual fellowship that is carried by the Amrita Institute of Medical Sciences with Walton Center for Neurology and Neurosurgery in United Kingdom. So the basic eligibility for the ISNAC fellowship, the fellowship in neurocritical care, and the dual fellowship, it is MD in anesthesiology. There are certain international opportunities that are available in neuroanesthesia and neurocritical care. There are some centers which are carrying out a uniform fellowship under the International Council on Perioperative Neurosciences Training. This is an international initiative to maintain the uniformity in neuroanesthesia and neurocritical care. And these are some of the hospitals in United Kingdom that are conducting this fellowship program in neuroanesthesia and neurocritical care. We have the National Hospital for Neurology and Neurosurgery in London. And again, we have the Cambridge University Hospital, again in Cambridge. And we have the NHS Foundation Trust St. George's University Hospital, again in United Kingdom. And there are a good number of hospitals in United States. I have not compiled the whole list, but I have just compiled some of the centers. We have Cleveland Clinic, we have Columbia University, Duke University, Stanford University, the University of California, and the University of Washington. These are some of the prime fellowships that are being offered in the United States. Then we have the Singapore General Hospital. That's also one of the internationally very renowned hospitals that is offering fellowship in neuroanesthesia and neurocritical care. And we have the one of the centers in Germany, that is the Technical University of Munich School of Medicine. And we have the University de Barcelona that also offers a neuroanesthesia fellowship in the Barcelona. These are some of the training opportunities that we have at the national and international level.
Thank you so much, Zulfikar sir, for bringing out so nicely all the technologies, the spectrums, the armamentariums we are totally engulfed into. Before I take up any queries,
you're muted. Kindly unmute.
I'm unmuted, sir. Am I audible, sir?
Yeah, go ahead, Ankur. Go ahead.
Yeah. So before I take up the queries, I now invite Professor Das sir to kindly share a few words and his experiences and how neuroanesthesia has progressed over the years. He has seen the full development of neuroanesthesia in the last 3 decades. Over to you, sir.
Thank you, Dr. Ankur. My sincere thanks to Dr. Naveen, our ex-dynamic secretary, of course still is dynamic, and also to Dr. Girija. As regards the acquisition of skill in neuroanesthesia is concerned, I fully congratulate Dr. Zulfi for nice deliberations. But another aspect I want to highlight, that is particularly in the neuroradiological procedures, that is at times the neuroanesthesiologists were requested to deliver hypertensive anesthesia for complex AVM or aneurysm surgery, where it is very challenging and one can use sodium nitroprusside. So that is another skill development. As regards the academic development is concerned, it is the field of research which is still a lot of work has to be done in neuroanesthesia and neurocritical care, which is also very rewarding. Because 2 of my students, they were judged, their papers were judged as the best paper in SNAC, which is being held in USA. So this is another field which is very rewarding for the youngsters. And coming over to the ICPNT, the Doha recently has opened up the ICPNT course. That is just addition to what the list shown by Dr. Zulfi. And coming over to the my students, particularly Deepak Sharma, I must name. He was number 3rd or 4th batch, 3rd batch of my DM students, who is he is the professor and professor of neuroanesthesiology at Seattle, and Dr. Tumbul is at Toronto. They are also doing excellent work in neuroanesthesia. So our students have gone abroad and they have established themselves as very good and renowned neuroanesthesiologists. And whenever you are choosing, because neuroanesthesia is a long duration surgery, and same thing is the anesthesia time. And of course, nowadays the bleeding has come down to more or less zero level. But the neuro monitoring, the cardiovascular monitoring, you will have to be very particular about. That is, the cardiovascular disturbances, you must inform the surgeons. You should not behave like the cardiac anesthetist. You must inform the surgeon. Once the surgeon stops handling, the cardiovascular problem settles down, and you can. But very rarely you will have to resort to the Nordreen or other things. This is one. So, but whenever you are taking up the neuroanesthesia, your brain may be saying you take up neuroanesthesia because it is the most complex organ the Almighty has given. So anesthesia must be very challenging, but always ask your heart and take a decision. Thank you very much.
Thank you, Dr. Dasher and Dr. Zulfikar. I'll take 3 quick questions from Dr. Pallav Pathak and Dr. Sherlyn Marina, and one by the name of anesthetist. Dr. Pallav Pathak have written also in the chat box also, DM cardiac anesthesia versus DM neuro anesthesia. If you want to further express, Dr. Pallav, you can unmute yourself and be quick. And Dr. Sherlyn and Dr. Mr. Anesthetist, you're also, if you want, quickly ask your questions to the panelists.
Dr. Pallav has asked, what is the future prospect of DM neuroanesthesia in Lucknow? Specifically, he has asked about the prospects in Lucknow. So, any person from Lucknow, because I know I did my PDCC from Lucknow. There is a good establishment of neuroanesthesia and neurocritical care. People are good at practicing tremendously in Lucknow. So I think it's a good prospect. Regarding salary, future, there is definitely a future. Zulfikar sir, regarding salary, would you like to say something?
Salary basically varies from... Yes, sir? Dash sir wants to say something.
No, you tell. I'll tell later. No, see, if you are joining...
Salary basically...
No, my point is,
yes,
if you are
sir,
joining any teaching institution, the salary is at par with the central government, which is very lucrative nowadays. And even some of the state governments, their salary, they have increased it to more or less or equal to the central government level. And as regards the private practice or the in private practice is concerned, corporate hospitals are concerned, it is very lucrative.
So just one query, because a number of residents would be attending the programs, senior residents, junior residents. Things seems easy as a neuroanesthetist, but Zulfikar sir, Das sir would agree that 24 hours round the clock you have to be available as a neuroanesthetist. So there should not be any complacency when you take up neuroanesthesia. Any brain tumor might herniate, patient might deteriorate, any traumatic brain injury might land up, spinal cord injury might land up. So as a neuroanesthetist, 24 hours round the clock you have to be available. So what is your take on it, Zulfikar sir? Work-life balance, how do you define it in neuroanesthesia?
It is definitely, neuroanesthesia is one of the very hectic branches. So basically, because of evolving specialty, and if one goes into neuroanesthesia, and then you start working in a hospital where you have a dedicated neuro surgical setup or a neuro intensive care unit, there is a lot of pressure on you. So if you want to come into this branch, you should come with passion. It's not basically for money. You have to come with passion. Money always comes there, whether you are in government sector or you are in private sector. In the government sector, as sir was pointing out, we have a good salary structure across all hospitals, particularly in the central government institutions. And even in corporate sector, as many of us were asking, there is a handsome salary. So this salary, it depends on the expertise, the experience. But it is definitely, there is a handsome salary, but the pressure on a neuroanesthesiologist is definitely there. One has to strike a work-life balance once it comes to managing home and work. There is good amount of pressure on a neuroanesthesiologist.
As I belong to Lucknow, Dr. Ankur, as I belong to Lucknow,
Yes,
I can say a few words about the question from Dr. Pallav. That Dr. Pallav, at Lucknow, currently there are 3 institutes, Dr. Ramano Lohia Institute of Medical Sciences, where I work. We are going to have a separate neuroanesthesia department in the coming years. Currently, SGPJMS as well as the KGMU Lucknow, which was earlier known as KGMC, King George Medical College, they both are having neuroanesthesia department. So there you get a job, you can get a job, and in any government institution, the salary is same, irrespective and irrelevant to your specialty as well as your degrees in your hand. So salary is same in whether it is you are in anatomy or you are in anesthesiology or in neurosurgery. So salaries are same. For the corporate, Lucknow now corporates have started coming in. Currently, we are having Medanta as well as Apollo, and a few semi-corporate type of hospitals are there, where also they are having separate neuroanesthesia department where you can be settled. And the salary at Dr. Zulfi has already told that depend on your experience and as well as your degrees. So just to inform about the.
Thank you, Dr. Raj, for that wonderful input. And thank you, Dr. Dash and Dr. Zulfikar for joining us today and gracing the occasion. And I'm really honored and humbled by the gracious presence of Madam Sushma Bhatnagar. To be honest, in between I called her and Madam, we can shift your session ahead. But she said, no, I'll wait for my turn and do justice to it at my own appropriate time. Madam, we are really sorry that we are running almost 1 hour late, but thank you for staying back there. And I hand it over to Dr. Nishant to do the honors for the session on Onco-anesthesia and palliative care. Over to you, Dr. Nishant.
Yeah, thank you so much, sir. And as you mentioned, sir, it is an absolute honor to have Dr. Sushma Bhatnagar ma'am with us. Anyone in India and practicing onco-anesthesia or palliative care knows Dr. Sushma Bhatnagar ma'am and reveres her. She is the current chief of the BRA IRCH, that is the Cancer Center of AIIMS in New Delhi. She's heading the Onco-anesthesia and palliative medicine department there. And I've had the good fortune of being there and witnessing the world-class work that they are doing. Ma'am is also the president of the IAPC since 2018, former IASP council member, founder of the CTC project, that is the Cancer Treatment Center project for Pain-Free India, and a former board member for IAHPC and APHN. She is the chairperson of the COVID services at NCI in Jhajjar. And there was a Lancet Commission report on palliative care, and she was a member of the implementation of the task force. She was nominated by ASCO for the Women Who Conquer Mentorship Award in 2020. She's also the convener of DNB Palliative Medicine by the NBE. She's the founder, DM Onco-anesthesia and MD Palliative Medicine at AIIMS Patna. She's the founder member of that. And the pain policies and the end-of-life care policies at AIIMS in New Delhi. She's also a founder of that. Recipient of the Leadership and Excellence Award among SAARC countries in 2012. Recipient of the IASP Award for Excellence in Clinical Research or Practice and or Policy Changes in Pain Management in the Developing World in Milan 2012. And this is just a portion of what she has done. I'm sure there are many, many more. And she'll be chairing the session today on onco-anesthesia and palliative medicine. And the career prospects will be discussed by Dr. Anuja. Yes, Dr. Anuja Pandit. She is also an assistant professor in the Department of Onco-anesthesia and Palliative Medicine at National Cancer Institute, AIIMS in New Delhi. She has Smile Train Foundation Gold Medal in 2013, the Dr. Kotur Memorial Gold Medal in the same year, 2013. The World Federation of Societies of Anaesthesia as anesthesiologist, WFSA Scholar of Nepal in 2015. She won the Dr. B.B. Mishra Young Anesthesiologist Award at ISACON 2022. The Indian Society for Trauma and Acute Care Bursary Award 2012. the AIMS IJPC Award in 2018, ESSO and ISPSM Award in 2018. Her areas of interest are onco-anesthesia, GI and HPB anesthesia, onco and critical care, as well as palliative medicine. So without further ado, let us listen to Dr. Anuja Pandit. Over to you, ma'am. Dr. Sushma, ma'am, before we start, do you want a few words? Ma'am, you're muted. Dr. Sushma, ma'am, you're muted, ma'am.
Thank you, Dr. Naveen, for inviting us for this important session. But I'm so sad that there were 138 participants, but now there are only 68. But it is okay. At least 68 people are listening. So I think like this. So, when I joined IRCH, there was no word of onco-anesthesia in the world. So, and we never used to get residents for cancer center. And cancer center was expanding and the number of hospitals were expanding. So to get the residents, I just thought that there should be a dedicated courses for onco-anesthesia. And we started thinking of dedicated courses. It took me almost 7 to 8 years to develop, to get approval that DM onco-anesthesia, which was first in the world. We have started at AIMS New Delhi, and now there are so many hospitals have started. Plus, there are we have also with the Dr. Rajiv Chawla, we have started DNB, FNB in onco-anesthesia. So, because this is a need, and Anuja will tell you how this is a need because it is justified. And simultaneously, as a pain physician, we were developing, we realized that there is, beside pain management in cancer patient, there is a need for many other symptoms which is intractable and at the end stage of disease. And simultaneously, palliative medicine was developing all over country. So we started developing palliative medicine, and we realized the 2012 Medical Council of India has recognized MD palliative medicine, and there were only one center was having MD palliative medicine. So we started developing palliative medicine also all over the country, and we started MD palliative medicine. Plus now there are DNV palliative medicine, and which again Anuja will explain you, and how a person can opt these two courses and what will be their future. I will tell you at the end. So and I am very proud that Anuja is first DM candidate of AIMS New Delhi, and she's the one who I have chosen that she should be explaining what exactly the onco-anesthetist and palliative medicine, what are the developments in the countries. Go ahead, Anuja, then I will speak at the end.
Thank you so much, ma'am. Thank you, Dr. Nishant, for the kind introduction. I must also add that I had the honor of being inspired by ma'am, being trained by her, and now I am working under her in her department. So thank you very much. I will be talking about these two branches, and I promise to wrap up in time and leave some time for discussion. So let me make a case for this specialty. It's one of the newest ones. So we need to know why it exists and why it's important. So everybody knows that cancer is the leading epidemic right now, and it is the second leading cause of death globally. So in 2020, where we saw 19 million new cancer cases in one single year, it is estimated to double in the next 20 years. And then in India itself, we saw like about 14 lakh cases in 2020 alone. And in another 2 years, we will be seeing about 16 lakh cases in one single year, with very high mortality of about 8 lakh cases in a single year, attributed only to cancer. So we know that cancer is the rising problem. And as being the anesthetist by a force of habit, we always have the habit of stepping up, be it COVID, be it pain medicine, be it critical care. We have always stepped up. And that is why onco-anesthesia and palliative medicine also has come up as a very promising and emerging specialty. So talking about the scope of onco-anesthesia, I get this question a lot. People ask me why or how onco-anesthesia is different. Well, let's just say it's much more exciting in simple words, where you not only give anesthesia for complex cases, oncological resections, complex surgeries like HIPEC, where you deal with a lot of temperature. All your hard work goes into managing temperature and hemodynamics, but also robotic surgeries, minimally invasive surgeries. And not just that, the anesthetist does not just think about the immediate outcome, but also about the long-term outcome and rehabilitation, long-term survival. The Onco-anesthesia game has actually stepped up to do research in preventing recurrence of cancer and improving survival by innovating new anesthesia techniques. So Onco-anesthesia does have a lot of role currently. And why I personally love it is because it is not restricted to an organ, brain, spine. We do a lot of almost entire thing except for the heart. And it is not restricted to an age group or gender. We do both pediatric and adult cases. It is obviously very challenging because most of our cases in anesthesia have, if not any known comorbidity, they have undergone some chemotherapy or radiotherapy, which makes it much more challenging, but it is so rewarding. And not just anesthesia, we do pain, we do palliative care, and in a lot of institutes, you do get to do onco-critical care as well. So how do you train for onco-anesthesia? There is DM, there are about 13 cases, 13 seats released every year of DM onco-anesthesia in the 3 aims that are mentioned here, that is Delhi, Rishikesh and Bhopal. Of course, there is a huge gap. This is a new specialty started in 2016, so it's just 7 years old and the demand is really high. If not the DM course, there is a 2 years FNB course, which is available in Jaipur, Chennai, Hyderabad, Delhi, West Bengal, Calicut, Kolkata, Mumbai. So major cities do have FNB courses, which is 2 years duration. There is also SOAPC accredited, that is the Society of Onco-Anesthesia and Perioperative Care accredited institutes for fellowship, which is a 1 year duration. So these are also present in prominent cities. Now, coming to palliative medicine, why do we have to talk about palliative medicine as a specialty for anesthetists? Well, let me tell you, there is absolutely no better person who can manage pain better than an anesthesiologist. We not just reduce pain, we actually have the power to numb pain. So, of course, pain management is important. Then comes symptom control. Well, let me just highlight that palliative medicine is not end-of-life care, as many people do believe. Palliative medicine is symptom control to improve quality of life of patients who have chronic illnesses. Now, if you talk about symptoms, the prominent symptoms these patients face is pain, delirium, sleep, nausea, vomiting, and all of these symptoms are actually one of the most important symptoms that we read as an MD anesthesiologist. So we have already mastered a lot of the palliative medicine. We just need to apply it in a different population. Coming to end-of-life care, why an anesthetist is best for this as well is because I think we are the only branch who has learned the skill of numbing the pain, sedating the patient to such an extent, or anesthetizing the patient to such an extent that he does not feel the pain of surgery. On the other hand, he still is breathing spontaneously, and that is exactly what you need to do in an end-of-life care situation where the patient is relieved of the symptoms, but is breathing and living a natural life till the end. Of course, we are the team leaders inside the OT, and we need to extend our power beyond the OT and step into a new role. The huge gap we need to address, there is a cancer epidemic. There are rapidly expanding cancer treatment centers across the country and across the world. But 2012, as Man just said, MD medicine, palliative medicine had started only in 2012. In the past decade, only 8 centers have started MD courses. And just 2 years ago, DNB palliative medicine had started. So there is a huge gap between the demand of palliative medicine physicians and the number of specialists that are present to take up these posts. One advantage of the current situation is that to be a faculty in palliative medicine in a teaching institute, most of the institutes have the criteria of an MD in anesthesia or general medicine, plus a senior residency of 3 years in that field, plus 1 year of palliative medicine teaching experience. So after your senior residency, if you opt to do a palliative medicine teaching experience for a year, gain that experience, and then you are eligible to apply for a faculty post in palliative medicine. So these are the courses that are present for palliative medicine. It extends from 15 days to up to 1 year. of course, like it was mentioned before in the previous lectures, the number of days of experience you have, the better it will be, right? So there is a 15 days course which will really help you sensitize to the problems and the subject of palliative medicine. But there is a 1-year course, which is National Fellowship in Palliative Medicine. There are multiple other courses. Some are online, some are in contact courses. For example, the CCPC course is a 5-day contact program where you, or it could be online depending on the center you choose. It is done all across the country. And then there is a 10 days observership in various recognized institutes. The National Fellowship in Palliative Medicine is a 1-year course where the classes are held online, and then there is a 10-year contact period observership, and then there is an exit exam. So there are multiple courses available, but I would say that basic principles of palliative medicine is a skill for every specialty to pursue. Even if you opt for neuro anesthesia, cardiac anesthesia, these patients do have chronic illnesses, and basic principles of palliative medicine are something that you should really learn. And the only way to do great work is to love what you do. That's what Steve Jobs said. So all the best to you in whatever you choose. You will excel at it only if you love what you do. Thank you.
Thank you, Anuja, for summarizing in time. I will also take only 5 minutes. That first thing, I'll come to onco-anesthesia, and I will answer simultaneously the questions which have been narrated in the chat box. I have seen the questions. That the first question was that whether DM onco-anesthesia will get a extras, like corporate hospital will be ready to pay extra to a DM onco-anesthesia than a general, something like this. The question was that whether DM onco-anesthesia will be honored. So it is already, it has already started, and I will give you the evidence of one of talk which I have given in the Royal College of Royal College of Medicine. They invited me to speak only that how we have started DM onco-anesthesia. So where there the two things I have spoken, very important, that why there was a need of super specialty. So if you really want to start super specialty, there should be 3 important factors. One is magnitude of problems should be huge. Second, Second, there should be many unanswered questions in that area. And third, if you will give a dedicated training or teaching and the application of that specialty to the patient, outcome will be better. So all 3 are existent because it's a huge problem. There are so many unanswered questions. We don't even know that whether morphine will work and morphine will cause recurrence of cancer after so many years. Which inhalational anesthetics is better? Whether regional anesthesia is better? Whether opioid sparing anesthesia is better? There are so analgesia is better. There are so many unanswered questions in cancer, and which we can really. We have to answer all these questions. So this is an important that. And then second thing, which really stuck to my mind, and which I can also feel, and we should also give that evidence, that in Sloan Kettering Hospital, when they started dedicated fellowship in onco-anesthesia, the mortality and morbidity drastically reduced in cancer patients. I'm not saying that general anesthetists cannot give anesthesia, but when we learn something in a focused area, I think automatically the quality will improve and outcome will improve. So this is what I want to say. And today, if not understood, but definitely tomorrow, when there will be a lot of cancer hospitals, a dedicated specialty definitely will come forward, and people will like to have trained onco-anesthesiologists in their hospital. Like I seen these days, when I came to Delhi 25 years back, there were only 4 hospitals providing cancer care, but now there are 27 hospitals providing cancer care in Delhi. So every hospital is coming out with a dedicated wing of onco-cap patients. So automatically an trained onco-anesthesiologist will be required. Regarding palliative medicine, I want to say something very important, which definitely you should listen. That palliative medicine is a dedicated specialty by Medical Council of or NMC. Now there are trained MD palliative medicine students are coming and DNB students are coming. maybe after 5 years, definitely they should get a chance to become faculty of palliative medicine. But when NMC asked me to make the proposal, anesthesiologist they have given the priority of an anesthesiologist who's trained palliative care physician, and the palliative care training is what Anuja has enlisted. If they have done some kind of a training, they can become a faculty of palliative medicine right now. This does not mean that after some time they will be there the senior most. Means like I can visualize that for next 10 or 15 years, the senior most palliative medicine or professor or head of the department will be a anesthesiologist. And it is not only anesthesia we have kept, it is medicine person can also become palliative medicine physician if they are trained palliative medicine. And there are certain other specialties like radiotherapy and medical oncology and some more. But anesthesia is one of them. So definitely for next 10-15 years, you have a chance to become. But I would not like that MD and DNB, in front of MD and DNB, anesthesiologist will be getting palliative medicine job after 10 years or 15 years. So this is what, and one more important thing I tell you, the respect of anesthesiologists till the way at AIMS or IRCH when you will go, a patient who is coming or entering in cancer center, whether it is NCI or IRCH, 4 people are looking after the patient together in the screening clinic. That is medical oncologist, surgical oncologist, radiation oncologist, and palliative medicine physician. Because 60 to 70% patients are coming with intractable symptoms, and straight away palliative, we are the one who are registering these patients. And once the symptoms get subside, or once we see that symptoms are reasonably well controlled, we refer them to oncologist, and then oncologists start treating them. So simultaneously, this is a clear-cut example of early integration of palliative medicine. So right now, many of our residents, those who have passed out from, those who have gone from IRCS, they have chosen dedicated palliative medicine as a career, and they are leading palliative care physicians all over country. But definitely after 10 years, when MDs and DNBs will be more, and we should be having a lot of hospitals should start a palliative medicine. There should be a lot of MDs and DNBs. So maybe future, they will be the leading this branch. One more thing which I want to tell, that recently I attended a meeting with Ministry of Health and Family Welfare, and chairperson was Honorable Minister of Health and Family Welfare, Mr. Mansukh Mandaviya ji. And there I have given, they were discussing the roadmap for cancer care all over India, because everybody is worried about the tsunami, growing number of cancer patients all over country. I said, lot of cancer hospitals are coming. We are talking about lot of big machines, of crores of machines, but we are just not giving any emphasis on the 50% of patients, those who are coming and they don't need any treatment for cancer care per se, but they need symptom management and good palliative care setup. So every cancer hospital should have a dedicated palliative care program. And now there will be a need of yours as an anesthesiologist, because there will be no enough MD and DNBs, but a trained anesthesiologist or trained palliative care physician as an anesthesiologist can lead that program. Because in that the meeting, it was minuted that it is desirable. Now it is an official document of Ministry of Health. It is desirable to have a dedicated palliative care program in any of the cancer hospital in this country. So every cancer hospital will have a dedicated palliative care program, and you can lead that program. And as Anuja said last, that whether we are neurologists or cardiologists, we all should have basic understanding of palliative care, because ultimately patient may go in advanced stage in any of the disease, and we should have a very different attitude of handling patient when they are in the end stage of disease or when they are dying. Thank you very much.
Right, ma'am. Thank you so much. And yes, as you mentioned, we should have a little bit of palliative medicine in every field, because I believe it changes a person itself, the empathy that comes with it. There are a few questions, ma'am, in the chat box. One is it good doing fellowship of Onco-anesthesia in Tata Memorial, Kolkata or Mumbai? This is by Dr. Arya Nair.
Yes, definitely. that you will do fellowship in Onco-anesthesia, and if after finishing fellowship, if you will go to any of the hospital where dedicated onco setup is there, you will be the one they will prefer to take you. Definitely. And these are the leading hospitals, and they are having lot of caseload and workload. So you will learn a lot. Definitely.
Absolutely, ma'am. Absolutely.
And I have answered this Dr. Nand's answer.
Yes. Then there is another question: is palliative medicine an OP based practice? OP means, I don't know, or is it done along with onco-anesthesia? Outpatient. Okay.
So in AIMS, if you will come, I don't know who is the person. There is an OPD which is round the clock. Maybe start on Monday and we finish on Saturday. Means 9 to 5 from Monday to Friday and 9 to 1. There is a room in AIMS at IRCH as well as at NCI. Whole day this OPD is going on, and whole day resident doctors and faculty, dedicated faculties are sitting over there. This means in cancer center, and when you will come and you will see that the maximum crowd is in front of our OPD, because most of the patients, they are coming in severe pain, with intractable symptoms, and they are waiting for a palliative care physician. So basically it is an OPD, as well as if intractable symptom, we admit the patient. So, I just want to share one more thing, that with the great difficulty in 10 years, from 1990 to 2007, I got 6 beds at AIMS Cancer Center with a great difficulty. But by seeing our work, by proving ourselves, automatically in National Cancer Institute, they gave us 65 beds for palliative medicine. Nobody can get 65 beds as in onco-anesthesia and palliative medicine. So they gave us that out of 720 beds, 65 beds are for palliative medicine. So this is the making a difference, and oncologists themselves, they will realize that yes, this is something different they are doing for our patients, and they will start acknowledging your work.
Yes, absolutely, ma'am. Really good work is being done there. Just final a few questions, ma'am. As Dr. Anuja has mentioned, there are only 15. We have 15-day courses also, the IAPC certificate course. So, what specific benefits, and why should we encourage most of our postgraduates in anesthesia to do that IAPC certificate course? The specific advantages.
This is very important, Nishant. Actually, I say that all anesthesia residents, they should do, because it is a sensitization course. We are not making them palliative care specialists, but this is a sensitization course. What exactly it is? Because people always, there is a big myth that palliative care is end of life care, but it is not end of life care. When they will attend this course, they will realize there is so much extra they can do for the patient, even in perioperative care. When they are going for pre-anesthesia checkup, when they are looking after patient and post-op care, there are so many other things. It is not only the physical aspect which is coming, which is with the patient is suffering from, and patient is suffering with so many aspects. A simple carcinoma breast patient, when she is presenting to you for a PSC, if you are talking only about PSC and not giving extra 2 minutes to the patient when she wants to talk so many other things, probably oncologist has not listened. But if you have a basic knowledge of palliative care, you will try to listen to her, and she will just say whether mere paal ud jayenge kya, mere bachon ka kya hoga, whether I will die. I think we can answer all these questions, and this will learn when we will join a basic course of palliative medicine.
Yes, ma'am. Just one final question, ma'am. There might be certain anesthesiologists who might be wanting to go to the periphery. You understand there is a lot of unmet need for pain management, especially that opioids and tablet morphine. What courses can the anesthesiologist do in order to get that? Is there a change in the policy regarding storage and disbursement of morphine or opioids?
Yes. So there is a basically, first, what courses? So IAPC basic course in palliative medicine, Part A and Part B is affiliated by Government of India, that if a person has done Part A and Part B course, Part A is theory course and Part B is practical course for 10 days, they can be a person who can become a recognized medical institute, and they can procure and they can dispense the morphine. And in 2000 NDPS Act, that is Narcotics Drug and Psychotropic Substance Act, there is a clear-cut that every doctor who wants to treat cancer pain patients, they can procure and dispense morphine. Only thing, they will have a responsibility that it should be accountable. Accountable in the sense that how many tablets you have procured, how many tablets you have dispensed. There should be someone should write. So we are also in IAPC, we are also doing pharmacist course. So if your pharmacist wants to attend, we are teaching them that how to store, how to procure, how to store, and how to dispense, and how to keep the record. This is what we are doing in 6 hours only with the pharmacist. So if pharmacist, I always say that pharmacist बाद में सीखेगा, पहले doctors को सीखना है कि कैसे procure करना है, कैसे store करना है और कैसे dispense करना है. जब हम सीखेंगे तब हम अपने staff को सिखा सकते हैं. So everything is included in these courses which we are doing through IAPC, and we have started a lot of other courses like for rehabilitation and all. So there are so many things we have started, but I don't think we have time to discuss all this. But definitely we have started all these courses, and safe dispensing of opioids is our responsibility. We have to teach them that early integration of intervention is very important. If intervention can help, intervention will definitely reduce opioid consumption and decrease unnecessary side effects. So all these things we can teach them, and we have created a safety circle where 10 steps are there. We have published that also, that if we will follow those 10 steps, definitely we will be following the safe opioid dispensing practice all over.
Right, ma'am.
Almost सबको नींद आने लगी almost.
No, madam. We are listening very careful and attentively to you. And to be honest, it has been a pleasure. And your smile, just the passion with which you are speaking, and your humility that you waited for your turn. And it was real pleasure. Anuja, well done. And
thank you, sir.
Under madam's supervision, it was a very crisp presentation, and only you stuck to the time. So God bless you. And I can see it's almost 9:45, so it's a half-day CME program going on. And I think we should thank madam and all the delegates for a wonderful interaction. And lots of questions have been asked, which have been answered also. And the recording will be available on different YouTube and Facebook, multiple channels. And I'm very sure the younger lot, the Yuva stars, will be benefited by the experience and knowledge of our such seasoned and expert anesthesiologists who are doing such a wonderful work in different specialties of anesthesia. Thank you all the experts for joining us today. And thank you all the coordinators, the chairpersons and the speakers. We'll meet same day next week for another interesting session. Thank you.
Dr. Naveen, I want to congratulate you because this was such an important and very important session for young anesthesiologists. And what I have suggested that this kind of session we should keep in ISA as a pre-conference workshop, so that those who want to join, or maybe in a session that in a main session that everybody can join, so that they will listen, because here only 138 people have joined, and there are almost thousands of people are anesthesiologists, and they all are coming over there. Everybody wants to. So if somebody wants to listen only neuroanesthesia, they will stay for neuroanesthesia. But I think this is such an important session you have organized today. I'm so happy. So I would like to congratulate you, Dr. Naveen, and your team. And Nishan, thank you very much for introducing us.
Thank you, madam, for those kind words. That's a good food for thought. But don't go by these numbers. Actually, to be honest, my experience over the last many years is that viewership is 100 times more on YouTube and Facebook. So last session which we did, there was around 500 live audience, but within 2 days, it touched to more than 5,000. So I'm very sure that I'll share the stats with you. And for this, I'm really thankful to this Anesthesia TV. Rahul Chaubey and Poonam are there, and they stream it all across the country, and not only in the country, but it is streamed in the SAR countries also. So
very good, very good.
So
Thank you.
And that's a good thought that we can keep it as a half-day session in the national conference also. I'll convey it to the relevant concern, because since we are...
It's just now, I just thought that this should be...
That's a good food for thought, and we're doing it in Gurugram only. So we can implement it here in the national conference. Thank you very much. Thank you very much to all of you. Good night.
Thank you. Bye-bye. Thank you, Anuja. Bye.
Good night, ma'am.
Very good presentation. Good night.
Thank you. Good night, everybody.
Thank you.